Great. So I'm just going to wrap up this session. I'm sorry we're running late. It's going to cut into our discussion time, so I'll try not to take my full 15 minutes. So one area that's really emerging is the use of simulation for process improvement, and that's really what I want to talk about next. So it's one of my disclosures, not relevant to any of the slides or any of what I'm going to discuss today. My learning objectives is really, very briefly, the background and importance of care pathways in clinical outcomes. You've heard a lot about that already. But more detail to define simulation approaches which may align to ERAS, and to provide a strategy with which to employ simulation technologies for a modern ERAS system. So we know about process mapping. That's really part of the ingredients of what we've talked about all morning through healthcare. And this is just as an example. This was a paper that was done in the BMJ, and really it is crystallized by a quote from Edwards Deming: if you can't describe what you're doing as a process, you don't know what you're doing. And so in this paper, they actually looked at the process of having patients come through the endoscopy unit. They really streamlined the process, which is a lot of what we're doing in terms of enhanced recovery for the patients, in terms of almost reducing in half the number of steps, reducing by 75% the amount of time that the patient spent in the endoscopy unit, and also reducing nurse staffing. And surprise, surprise, the patients were happier, the nurses were happier, and it cost less. And so when you think about that, you have this kind of care pathway. This is a generic care pathway for any patient who may need an intervention. And when we think about this, we have the preoperative, the operative, and the postoperative. And when we think about simulation, it's very much focused on the operative or the technical skills, certainly within the surgical domain. So what I did many years ago was really looking at this surgical pathway and developing a concept where let's put an educational framework onto this of knowledge, skills, and attitudes. We all know that as a very clear framework that's used in every domain, even beyond medicine. And then what are the outcome measures that we think are important there? And this can kind of give us a scaffold or a roadmap for how we may think of simulation when I originally designed this for resident training, but also for quality improvement. So why are we doing this? Well, we know that healthcare could be safer. And what we want to do is get healthcare as safe as bungee jumping, essentially. So in terms of some of the work that's been done in many units, we're talking about team-based implementation. So part of that is within the operating room. And so when we have a simulated operating room, this is the first one that we developed in London. Now there are many all over the world. You can actually look at the team training in terms of having those discussions within that operating room suite, thinking about enhanced recovery and what are the principles within that suite, and practice that. And it's been shown in a different sphere that medical team training of staff in the operating room actually impacts on surgical mortality. So my thought process that we're working on right now is how could team training specifically around enhanced recovery really impact on better implementation of enhanced recovery and even better outcomes of enhanced recovery. And then we need to think more broadly also about what happens post-operatively. So this is a photograph of the simulated ward that we had in London. We're just building one at McGill right now. And next you can just see a quick video of one of the residents undertaking a simulated ward round. And this looks like a ward. It has standardized patients as actors in there, and they can take on the role. So you can think about this as really having those scenarios, those enhanced recovery scenarios, and trying to teach not just the residents now, but the whole team, the nursing team, the surgeons, the other members, the nutritionists, and so forth, about how to take care of these patients to implement enhanced recovery protocols. And so in terms of resident education, we validated this. We showed that there was a real difference between junior and senior residents, even in terms of potential adverse events that could occur, such as prescription errors or really simple adverse events in terms of allowing a patient to eat and drink despite them probably needing to go to the operating room because they have peritonitis. And so when you think about this, the concept that I've developed has been I've called it simulation care pathways, or SimCare, and it's to define a pathway of care for a patient with specific disease aspects. So you could think about this for enhanced recovery for, let's take the colorectal pathway, let's take the 8-hour appendectomy pathway, let's take the liver resection pathway. And really you look at the pre-op, you simulate that, what do we need to tell the patients in that environment? What is the engagement? What is the prehabilitation that we need to engage in all of that? And then you have the intra-op, so you can have the team training within that, and it's less about the actual surgical technique, more about what's happening through the process of engaging the patient and the team. And then, just as I've shown you, doing through simulation a post-op management. And this, you can actually do rapid process simulation. So within the space of about 2 or 3 hours, you can go through a week in the patient's history. So they can be seen by the team. That's a 10-minute simulation, and then it's now day 3, it's now day 5, and so forth. And so this is an example of what it looks like in the pre-op clinic. This is an example of what it could look like in the intra-op and then the post-op. So they look very real, these photographs, and they're done in a simulation center. And then, we can even have, I mentioned quality improvement, and part of quality improvement is actually rating the performance. We need to know that we're doing this well. It's not enough just to do it, just to say I'm doing enhanced recovery, just to say I'm doing simulation of enhanced recovery. We really need to be monitoring this and measuring this to say, how do we, where are the areas that we're missing that may need to be improved, or where are the areas that aren't working in terms of the system? And so part of the work that we've started doing, actually, which is really focusing on enhanced recovery now, is, just as you've heard about the ERP pathway, is really thinking about a simulated patient pathway. Really, we're doing a systematic review at the moment of looking at which is the ideal, in terms of an evidence-based pathway for patients with right iliac fossa pain who then proceed to an appendectomy. And so you can define, in terms of their history, examination, the labs that need to be done, the diagnosis that needs to be made, in terms of the management plan of them having radiology or going straight to the operating room. And so this can be a pre-op, intra-op, and post-op pathway. And you can have different pathways, younger patients, older patients, patients with complications such as a perforated appendix. How do you manage those? And more recently, what we've also been working on is doing this in online. So this is something that we call virtual worlds, or an online simulation. And so here, can we have the video, please? So here is an online simulation of being able to really go through a case, because it's difficult to have all that physical space, having the simulation center, the simulated clinic, the simulated ward. Here you can see the patient who's in the emergency room, make the diagnosis of what's wrong with the patient, and really get that engagement, look at the laboratory tests, look at the vital signs, as you can see here. And so anyone can do this, and they can do this on their laptop, and they can use this as a tool really to learn about what they should be doing. And we can also do this from the nurse's perspective on the ward, so we can really, and the other thing about this is everything that's done is recorded, so you have all that information automatically, and then that can give us some idea of how good are the people that are working in the team at actually doing this at an individual level and also at a team level. So here you can see, we've looked at the labs and we've looked at the radiograph and so forth, and then we can move forward with doing the plan. And then more recently, we've just looked at enhanced recovery simulations, so specifically what I'm talking about in colorectal surgery. So we actually designed virtual online patients in the pre-op setting. You can see the history, the examination, obviously the previous investigations with regard to the tumor, and then whatever investigations are required in terms of anesthesia, in terms of radiology, and then scheduling the patient, and really having those factors. You can see the pre-op fasting, 6-hour solid, 2-hour clear fluids, carbohydrate loading, all these kind of things. And then what you do, and then you have the discharge plan when they go home, and whatever else they may need. So you can have this, and you can just take your standard pathway right now, and you can simulate this in your own center. You could even simulate it in situ in your own clinical space. But what we decided to do, can I just have the video again, so this is one of the residents going through the simulation of the pre-op. This is on the virtual worlds. So they're going through, seeing what needs to be done, and then going on doing the operation. So now they're doing the lap colectomy. again on a simulator. So they're going through and doing part of that on a virtual reality simulator. So it kind of creates that pseudo-reality that, you know, you've just seen the patient, prep them and so forth. Now and then when they're done with that, they come back to the computer and then they do the post-op, and they do, you know, post-op day 0, 1, 2, and so forth. And so they finish that whole aspect of the pathway. And so we've designed that, and we're now just working on implementing that and looking at the rate of uptake of enhanced recovery, and also the quality of that uptake as well. So another quote by Edwards Deming, he's pretty frank. We've learned to live in a world of mistakes and defective products as if they were necessary to life. It's time to adopt a new philosophy in America. So with that, thank you so much. Can I ask the other panelists to come up, and then we've got about 10 minutes for a discussion. Thank you.